Hello everyone, I am back to share a patient case. I have decided that I will let these be wordy because I have a lot to explain and I really want people to understand what we're doing because I think the nuance is important. I realize kind of the lighting or the editing is not going to be ideal. I've been waiting for an ideal time to resume making videos to post on YouTube and possibly Instagram. That perfect time has not arrived, so I'm making do with the options that I have at my disposal. But let's get into the case because this patient scenario, this patient presentation is basically classic. And it's classic sciatica. We'll talk about what the word sciatica means, but sciatica is just a general term that's not really that descriptive of what's going on or what is needed as treatment. But a lot of people have radiating or radicular symptoms into the lower extremity that emanate from a nerve root being irritated in the lumbar spine, the low back. The low back is L1 to L5, and the sacrum starts below that at S1. Most of these problems, I think the research shows about 90% of these problems are going to be at the L4, L5 segment or the L5-S1 segment, which would primarily be affecting the L5 nerve and or the S1 nerve. So this woman in her 40s presented to me with symptoms in her right low back that radiate all the way to her foot. It's pain, achiness, discomfort, weakness in the leg as well. When I asked if there's numbness and tingling, which is also very often present, especially below the knee, she reported no numbness or tingling. These symptoms had been there about 6 weeks. She thinks they were related to lifting and moving firewood a few days prior, which involved bending forward of the low back, which is flexion, and rotating the low back. The symptoms were pretty constant. They would disturb her sleep considerably. They were unchanging in the last several weeks, although acupuncture provided temporary feeling of looseness. No real changes though. I ask people often, is it getting better, staying the same, or getting worse? She said it's staying the same. Symptoms are a little bit all over the place because not all over the place. The mechanical impact of movements at positions is a little all over the place, meaning not that helpful in determining exactly which direction is helpful because lots of things disturb symptoms or exacerbate symptoms. So sitting, depending on the chair, could make her worse. Rising from sitting could make her worse. Being still was worsening. Lying on the right side and lying on her stomach made her significantly worse. Worse in the mornings, and then worse around bedtime. She did report feeling a bit better standing, and that walking was the most relieving activity for her. Again, symptoms start in that right low back, through the buttock, the posterior lower extremity primarily, really kind of, at the end at least, really pronounced right behind that right knee and right in the lower right buttock. Kind of what we call the sit bones, where the hamstring tendons begin at the bottom of the buttock. Like I said, disturbed sleep, which is a big factor. In the past, she reports she had sciatica once. She couldn't recall which lower extremity it was. Let's go back to the word sciatica. Sciatica means the sciatic nerve is irritated. The sciatic nerve is comprised of L4, L5, S1, S2, S3. As I mentioned, most times it's going to be L5 or S1 that are impacted. But sciatica tells you that the nerve is irritated. It doesn't tell you where the nerve became irritated. For example, if there was a gash in the back of your thigh, that could irritate or rupture or injure the sciatic nerve. Similarly, if you fell on your buttock, that can irritate the sciatic nerve. Those 5 lumbar and sacral nerve roots come out separately, and then in the buttock, those 5 different nerve roots come together, and that's when we call it the sciatic nerve. The sciatic nerve is a peripheral nerve because it originates in the periphery, in the buttock, It's not a nerve root, which are named by the section of the spine that they exit and the number in a sequence. So again, sciatica it's a fine term, but it's not specific, it's not medical enough. It doesn't tell you where the injury is occurring or what the injury exactly is. It just means that that nerve is irritated. It could be irritated for non-musculoskeletal reasons as well. But if someone reports right low back to the foot symptoms, until proven otherwise, we're thinking that one of the nerve roots or more in the low back is irritated. And irritated is also a general word. We could say compressed, we could say pinched. That nomenclature is not that important because we know it's just being aggravated, it's being injured. And we as clinicians want to figure out, well, how do we unirritate it? Is this an injury that will respond to movements? Is this an injury that needs time? Is this an injury that is dominated by inflammation and therefore needs anti-inflammatory help? Is this an injury that is dominated by a structural lesion that is not amenable to movement or time and that needs surgical intervention? Those are the main buckets of what we think of as a nerve root injury in the spine. Now, most are amenable to movements and education. In my education, I learned about strengthening the muscles around the spine, stretching the muscles around the spine, flossing or nerve gliding the sciatic nerve or the L4, L5 nerve roots, for example. I don't think that way anymore. I think we have to look for, is there a specific way to unirritate that nerve? Oftentimes it's one direction of the low back that will free up that pressure on the nerve. Sometimes it's two, and in cases like our report today, we did end up using 3, which is pretty standard for someone whose lumbar spine is shifted in one direction as hers is, very subtly. So that's a point that I want to kind of highlight as well during this patient case. So she tried a muscle relaxant, nothing major in terms of help there. I don't really see patients ever tell me that muscle relaxants really help their symptoms. I don't think there's a lot of strong evidence for their use. However, they do seem to be prescribed quite often. They often make people drowsy. So insofar as they make you drowsy and fall asleep and therefore feel the pain less, they can be helpful in that regard. Leg is not giving out on her. I'm curious about how weak it actually is. No red flags in terms of weight loss, for example, or prior history of cancer. No imaging to this point, which is a bit rare for someone to live with 6 or so weeks of intense pain down the lower extremity. Most of those people by then have sought some type of musculoskeletal care because of the level of pain and functional disability, and or they've seen a clinician who, even when it's not necessary, has prescribed imaging. But to my mind, I'm thankful because I think a lot of people who see MRIs do fall into the category of getting a bit more scared or a bit more cautious about their spines when that's not necessary. So her history is pretty straightforward. It didn't take very long to take the history for this patient. She wants to get back to Peloton, get back to heavy weightlifting. She's an active exerciser. She has flexibility in her work in terms of sitting and standing, so we did talk about posture. So in the physical exam on day 1, when you lift up her shirt, you can see her spine is shifted ever so mildly to the left. So that means the shoulders are a little bit left on the trunk. That is classically presenting with right-sided symptoms, which we would call a contralateral lumbar shift. So shoulders to the left, signs on the contralateral side, primarily on the right. There are ipsilateral shifts, for example. They're shifting left, the symptoms are on the left. We don't really treat them very differently, but they tend to have a poorer mechanical prognosis, but you don't know unless you try to have a mechanical solution. But she is very subtly shifted, and it kind of highlights the importance of lift up the shirt and look at the spine. Now, the biggest thing I tell patients is if you're wondering if you're shifted or not, see if you can correct it. If you can place your hand on your lower rib cage or mid rib cage and move your spine and appear straighter, then there's likely a shift. The question after that becomes, is the shift related to the current symptoms? So sometimes I see that shift and I start asking, oh, have you always been like this? Did you know you were shifted, etc. But especially if you move that spine that half an inch or inch, or in more severe cases, several inches, and they definitely can tell that they're shifted because they're so off center. If you can correct it and it hurts when you do it, that's also a strong indication that it's relevant to the current problem. But for her, I could move her and she could see in the mirror that yes, when you move me, I am straighter, although she did not perceive the shift, had not picked up on it before. Again, it was subtle, but for me, it does explain a lot in terms of people with a lateral problem. So if she's shifted to a side that's lateral versus sagittal, front and back, those patients tend to report that most things make them worse, and they're not finding a lot of movements that make them better because the problem is on the side and they're not really ever going into positions that are conducive to that. But going back to the history, she did say she felt best lying on her left side. So that can line up to someone having a side problem, a lateral problem in the spine. So subtly shifted, I circled on my examination, mild shift. Looking at strength, I do myotomal testing primarily below the knee. I'm not usually going to apply a lot of pressure to the thigh to test the muscles around the hip, for example. In someone with severe lower extremity nerve root symptoms, I can always test that later if I want, but it's just, I'm not going to get a legitimate test if I don't put a lot of force through it, and I just don't find it's worth it or an imperative piece of the puzzle to helping what we want to do today is diagnose as quickly as possible. So I did a myotome test. Myotomes are just groups of muscles in the extremities that relate to certain nerve roots. And we have these maps and we know them. They are not disputed, although there are some idiosyncrasies from patient to patient. But we know, for example, that the L5 nerve root is in control of lifting the big toe up, the first toe up, so extending the big toe. So her big toe extension was weak at 4- out of 5. 5 out of 5 is the strongest, which is normal strength. And her dorsiflexion on that side, so bringing the ankle up, the foot up, which is controlled by L4, also weak. I gave that a 4- out of 5. Moving on, neurodynamics, so nerve tension in the lower extremity. I would expect a person reporting symptoms like this to present with nerve tension in the sciatic nerve or in the nerve roots of the lower extremities, and she did. So lying on her back, I am asking her to relax her leg. I'm lifting it straight, making sure I hold that knee so it doesn't bend, and the bottom of the heel. It was about 75 degrees with lower extremity symptoms on the right. 75 degrees for some people is their normal, but for her other leg, for her unaffected leg, it was 90 degrees. So it was an obvious difference left to right. The lower extremity that had the symptoms and the lower extremity that did not. Moving into the movement exam, I wanted to look at flexion, extension, left side glide, and right side glide. And we know she's already in a left side glide because her left shoulders, her trunk, have moved left on her pelvis. So flexion is forward bending. I have people keep their knees straight, run their fingers down their legs as far as they can go. She can reach the floor. I asked her if that's normal for her. She said she's missing about an inch. She reported pain during movement. Extension, stand up straight, hands on your hips, lean back as far as you can go. I put that she had major loss. So for that, I'm thinking at least 70% loss of range of motion into extension. That created right low back pain. Moving into left and right side glide, I stand behind the patient. I have her put her feet under her shoulders. I stabilize the shoulder and I gently push the pelvis one way and I push the pelvis the other way. I put both of them had about a minimal loss, which would be roughly 25% loss. The left side glide created right lower extremity symptoms. So as I've said before, you don't know a person's true range of motion until you try to make it better and see if you can. So I have to put what I think it is based on comparison with thousands of people that I've seen, based on the fact that this is an otherwise healthy, extremely active and strong woman in her 40s, what I would expect that to be. Also, the fact that she can almost palm the floor in flexion typically makes me think she's missing a ton of extension if she can barely move backwards, because I would expect her to have a concomitant large amount of extension, and similarly in right and left side glide. So I'm just getting what is there right now. Whether or not that's a true 25% loss or 75% loss will be borne out on whether or not it improves or changes for the better. All right, so now what I wanted to do with a patient who is glided to one side, a lumbar lateral shift, the first thing I want to do is try to unshift the patient. So for her, we went to the wall and I had her do right side glides. So pushing her pelvis to the left, so her shoulders rectify back to center. So now we're shifting the shoulders right. So we did about 150. I had her just keep going with correct form. I'm watching, I'm asking how it feels. I didn't go all 150 before I retested, but in some, that's about how many we did. Along the way, I did stop and retest the baselines. The baselines for her: movement exam, myotome, so muscle strength, and the neurodynamics, the nerve tension. 3 main areas. For her, when she did the side glide, it would produce some symptoms, but it would not be worse afterwards in the right low back. And it would also produce some symptoms in the right knee, or increased symptoms in the right knee when she did it, but they did not remain worse. So afterwards, she's standing there, I'm like, are you worse for wear for having done this 30 or this 50 or this additional 50? The pain decreased with repetition, so I wrote that in my notes. Each time it's getting better in terms of symptoms. And it produced some left low back pain while she was doing it that also did not stick around. After the sets, with a sum total of about 150 repetitions, which, mind you, you can do 1 repetition in about 1 second, so this does not take very long. She had decreased nerve tension in her lower extremities with the passive straight leg raise test on the right. She had a slight increase in extension in standing, and her toe and her dorsiflexion were now at least a 4+, if not a 5. So going from a 4- up to a 4+, again, 5 out of 5 is normal. So almost normal, but probably still a little bit of a deficit. Because of those positive changes, I made that the motion to continue to investigate over the next several days. She was instructed to do right side glides, about 20 or more, every couple hours, every 1 to 2 hours. We did not discuss posture too much because it didn't seem to be really important to discuss at this juncture, but I did mention try to sit up straight. I think that's relevant, but we did not want to go into a lumbar roll. A lumbar roll is pushing the patients back into extension. We don't want to look at extension right now. We just want to look at right side glide. So I also cautioned her to reduce the most painful activities as much as she possibly could. The second visit was 3 days later. She said she was consistent with the home exercise. Maybe she felt a bit more range of motion. It was no longer painful to do. She had an especially bad day the day after, but then back to her normal. And I remember asking her, is this the type of day you may have had in the past 6 weeks? Or do you think this was especially bad? She said, no, I would have days like this in the past. This wasn't especially bad. And she wasn't scared about continuing with the side glides because she didn't see that this was related to doing the side glides. Of course, if people stop and say, I'm scared, and they email me or call me, it's my job to kind of figure out if I can over the phone what to instruct. But sometimes these exercises do make people worse. And therefore, in almost all cases, that's temporary. But I say stop the exercise if you're concerned that this exercise is what's making your symptoms worse. And we talk about what's a peripheral symptom, what's a central symptom, what is allowed with these exercises. In general, if we're doing a spine movement and the pain is getting a little bit more intense or more intense, but it's coming out of the periphery, out of the toes, foot, leg, knee, thigh, buttock, then that's a good thing, and we can reduce the dosage if that intensification of pain that's closer to the center is too much to bear. We can reduce the frequency, but otherwise that is a good sign as long as it's coming out of the periphery. Now, doing an exercise that just simply increases central pain and the distal symptoms, the symptoms down the lower extremity or upper extremity are still consistent, still the same, that's not an improvement that we're looking for. That's just creating more pain. That would be a sign generally to stop. So her report is basically, I'm the same on visit 2, 3 days later. So what did I do? I looked at nerve tension again. We're going to test those things that I think are the most helpful, the most instructive. Nerve tension on the left was still about 90 degrees. On the right, it was better, about 80 degrees with decreased pain. 75 degrees to 80 degrees, I cannot eyeball without a margin of error. But the decreased pain is something she reports. I'm often asking, compared to 3 days ago, how does this feel? Or compared to 10 minutes ago, how does this feel? I tell my patients I work in comparators, meaning I want you to tell me, is this worse, better, or about the same? Don't tell me it's good, it's fine, it's stiff. I want to know, and when I'm asking this, it's because of an intervention. Is it worse, better, or about the same? That's what I need to know. I can test things and tell if they're worse, better, or about the same, but symptoms are going to be driving this process. Symptoms are really important. Signs should go along with symptoms, meaning if symptoms are improving, signs should be improving, and vice versa. But the symptoms are really what matter to the patient, so I'm going by them preferentially to the signs. So nerve tension, a tad bit better, but importantly, not worse. So the right side glides, she's done about hundreds a day for 3 days, not worse. Movement, she still felt a hitch going down into flexion, so pain during movement. Flexion's about the same, slightly more extension with right low back pain. Improvement in the right side glide, and left side glide, still about a minimal loss with pain. So I asked her to show me how she did the exercise. Her demonstration was great. The range of motion was still quite obstructed. So we can test side glide in standing, but I find, or what I've found over the years by doing this so much, is that to have a better picture of limited side gliding range of motion, get on the wall and have the patient compare left to right. A funny thing about this patient example is that when she got on the wall the first day and I said, let's do some right side glides, I was like, whoa, you're really limited, which was not that apparent in freestanding without the wall. And she thought her range of motion was pretty good. And I said, no, I think you're missing like 50% of your right side glide because our hips weren't even coming close to the wall with the pillow there. On the second visit, she said, I didn't believe you that you told me I was so limited in my range of motion into right side glide, so I had my husband do it and he could easily have his hips hit the wall. And I was like, yeah, you'll get there, it's just not there. So for me, I didn't like seeing that when she did the exercise on the wall, she was not getting significantly more range of motion. That's something I'm looking for. In addition to the movements, the 4 movements we do in standing. So same range of motion. So this is when I went to sustained. Now, I have personal experience that sustained side glide is really what helps me when I have a lumbar shift, and my spine has shifted 3 times in my life at a minimum to large degrees and with a lot of pain and functional disability. So I know the power of sustain. I've also just learned this from my patients that sometimes, even though you're doing 1,000 repetitions, you need to hold it in that position to see this thing actually change, which kind of makes sense, right? If the shift has been stuck there for 7 months or 7 weeks, 6 or 7 weeks, it can use more time sometimes to actually change for the better. So we did 2 for 15 seconds. I retested. I wasn't that happy with any positive changes, meaning there wasn't enough positive change for me to think that 15 seconds was sufficient. We did a few for 60 seconds, and then we started seeing the change. So I wrote down that we did 4 sets of 60 seconds. After that, on her back, passive straight leg raise, much better tension, about 100 degrees bilaterally with less pain on the right. Flexion and standing got better, extension and standing got better, decreased pain with the left side glide and standing. And before, she had said, you know, lying on my stomach is horrible. So I was like, oh, let's just get on your tummy and see, compare this to a week ago when you were on your tummy. She said possibly it was better, but it was about the same. So I decided to continue with the side glides, but doing it sustained. So her instructions were right side glide on the wall, sustained, 60 seconds every 1 to 2 hours, increase the time if she was able to, especially if she noticed that the more time I hold it, the better you feel. Visit 3 was about 10 days later. She reports 50% better overall, which is symptoms in the right low back down to the right foot, increased side glide range of motion. So she's noticing that now on the wall, her hips are getting close to the wall. And she said, she told me, she said, now my hips hit the wall, which was evidence that she was missing significant range of motion there before, which clinically makes me think that the lesion or the problem is on that right side, which correlates with her symptoms, of course, and correlates with the fact that she was shifted to the left. Now, I think the most likely explanation of this is the nucleus pulposus of the disc has shifted a bit to the right. That is a very controversial statement. We don't even have to talk about the disc in this case because we don't have to explain MRI findings, for example. But I do explain to patients, especially when they're curious, what do you think is happening? I say, this is the theory that I subscribe to because it makes the most sense versus, you know, a bony problem or one of the kind of external ligaments or a muscle problem or a tendon problem. What adds up for me is that there's been a shift in the balance of the disc, and that's, I think, what we're actually effectively changing. But it doesn't really matter what I think if what we're doing is restoring range of motion, strength, nerve extensibility, and symptoms are going away. But I do believe it's the model of best fit, and I think other explanations fall short as to what is actually happening in terms of anatomy and physiology in the spine, especially when we place a very specific load or force through it repeatedly every 1 to 2 hours. So she did also say, hey, when I get on my stomach, it's less painful now. So I looked at her spine, brought up the shirt, no shift anymore. Toe extension, now 5 out of 5. Dorsiflexion, a hair short of 5 out of 5. I wrote down 4++, which isn't a very medical term, but to me, I know what that means, meaning there's a little less strength than I would like when I push with all my strength down on that foot. Symptoms, or left and right nerve testing, lying on her back, me passively lifting the left and then passively lifting the right lower extremity, were symmetrical at about 100 degrees. And the right still felt a little bit different. Movement exam, no loss of flexion, or she said she's still about 95% better. Has 95% of her motion. So she gained a little bit, but she's not quite there. Extension I put as moderate loss versus major loss, so we're getting better. Less pain in the right lower extremity and right low back. Just right low back. I also wrote down here less deviation, so I guess I had noticed deviation in the past, which is if you look from the very front at the person extending and flexing, do you see them go to one way or the other? Side gliding I now put for the right and the left, they felt symmetrical with no loss. However, the left side glide still produced right low back pain. So I asked her to show me the exercise you've been doing. She showed me the sustained side glide. It looks really good. Now I wanted to see if we could, since she was 50% better, my question for those scenarios, especially if the patient's been doing this for 10 days, is do you think you've plateaued or do you still feel like each day you're getting a little bit better? She said, I feel like I've plateaued. So for most patients, if we have a lateral procedure in the spine, a side glide, an extension with hips off center, flexion and rotation, or in the neck, rotation or side bending, for a lot of those people, they will not resolve 100%. They will resolve somewhere between 50 and 80%. And then I'm looking for the plateau. when do you plateau? When you plateau, we're going to see if going to a more sagittal motion is now indicated and fruitful. She is still missing at least 50% of her extension, so something is still blocking her in the sagittal plane from extending. So if she said, no, I haven't plateaued, every day is a little bit better, I probably wouldn't have changed anything. But because it has plateaued and because I know how lumbar shifts tend to get better with side movements, and then we work our way around the clock. We go from 3 o'clock, then maybe to 4:30 to 6. We're making our way back to extension at 6 o'clock. I wanted to investigate with her extension in a side glide. So extension with the hips to the right, hips to the left, away from the side of pain, which means shoulders to the right. Just like the side glide on the wall is shoulders to the right, hips to the left. So we did extension in line with hips to the left, away from the right side of pain. I had her go on her elbows for a while just to see how she tolerated that for several minutes. And then we did the full pressing up with the hips off center, lock those elbows and sag. It produced back pain, but not worse. And when she got up, she had better extension in standing. So based on that, which is not a lot of testing, but based on that and based on seeing a lot of lumbar shifts and how they typically respond, I was very comfortable with giving her extension line with hips to the left, away from the right side of pain, 10 every couple hours, and to remain on the sustained side glide about twice a day, just to make sure we don't lose any of that gain, because we've gained 50%. And I told her, just like I tell other people, if you notice that we're backsliding even more, then that means you can't give up the high frequency of the sustained side glide yet. Continue to do it. But she was more than happy to do a minute on the wall in the mornings and a minute in the wall in the evenings, for example. And then every couple hours do the extensions with her hips to the side. So that was visit 3. Visit 4 was 6 days later. She reports 75% better overall. She says that lying on her stomach is a lot less painful. The symptoms now, they've come out of the lower leg. So they come out of the leg and foot from below the knee. Now they're kind of centered like right at the knee and right at that bottom of that buttock, like I mentioned before. Those were kind of those sticking points that were still really uncomfortable / painful. So I looked at a few more tests just to see. I had her do some lunges. They felt fine. Just air lunges, air squats felt fine. Neurodynamics, still about 100 degrees bilaterally, feeling better on the right. Not 100% on the right though. Flexion about the same, extension better in standing. We're encroaching on minimal loss now, and definitely no deviation, and no pain with the side glides. So that's improvement. I had her show me the home exercise program. Her form was great. Extension line, hips to the left, lock those elbows, sag the hips. We did about 40, and we didn't do 40. I just reviewed the extension with hips off center and she was doing it correctly. So I thought it was probably time, since extension is still significantly lacking in standing and the side glides are looking good, that I thought it was best to just test pure extension. So we did 4 sets of 10 pure extension. She remarked to me that she could feel it in that right low back, just like when she did the extension with hips off center. So that makes me comfortable, even more comfortable being like, let's abandon the hips off center and go to pure sagittal extension with the hip sag. We did 4 sets of 10. Afterwards, increased flexion in standing, and even side glides felt a little bit better to me, going bilaterally. I wanted to just take a look at sustain to see if she could tolerate it. So I had her lie on the floor up like this on the couch. We did just 10 seconds. I was curious how her body would react. She said it was the same pain as extension and line. So I actually thought it would be a lot worse based on my experience with these types of people, but it wasn't. Sometimes people can only tolerate 2 or 3 or 5 seconds. It's really aggressive. But she said, no, it feels the same. So I told her, if you want, you can add some sustained in to just try to make this better even faster, but we can also just be a little bit more conservative. So the conservative approach was get on the floor, move your hips to the side, still do about 5 with the hips off center, just to make sure we don't lose that gains, because we went from 50% better to 75% better. So do about 5 repetitions of that, then get those pelvis straight, be straight, do about 10 extensions with hip sag every 2 hours. continue with the side glide, sustain for a minute, 1 to 2 times a day. And again, she could try the couch if she wanted to be even better. So visit 5 was several days later. I actually forgot to write the date on this, so I'm not quite sure. But she reported being more than 90% better. It's only in the right low back, nothing in the lower extremity. She can still feel pain at end range when she does the prone lumbar extensions with the hip sag sometimes, but not every time. She did pick up on the fact that if she lies on her back and lifts both legs straight, which she will do for some exercises or some things when she works out, that right knee still wants to bend a bit. And that correlates to the nerve tension we've had in the past. So it's still a tiny bit of nerve tension when really challenged. So that became a really good test. Is not for me to do it passively, but for her to lie on her back and bring both legs up straight. She only tried the couch exercise twice for 15 seconds. Otherwise, she was consistent with the home plan that we had already discussed. So she wasn't curious to kind of push the envelope with that. So today, muscles were fine. Long sitting toe touch, which is similar to what she described, being on her back and lifting both legs straight. So long sitting on the floor, feet straight out in front of you, legs straight out in front of you, touching your toes. That right knee wanted to just bend a little bit. So there's not that extensibility in that sciatic nerve, probably because L5 and or S1 are still irritated. That was a sign that we could use. So that was our sign. Flexion looked good. She reported no loss in flexion. Extension I put still as a minimal loss with right low back pain. Side glides looked fine. Left side glide this time returned to the right low back pain, but nothing, we're talking very minor at this point. So I said, let's pursue more extension via force over time, which is sustained. I tend to use sustained more than applying overpressure with my hands or overpressure with a belt or getting a spouse or a child involved, just because it's easier and I'm not seeing it take any longer. If you can do an exercise independently, I think that just really hastens improvement compared to having to rely on using another person or relying on getting out a belt and affixing it to something, for example. So we did a lot of sustained extension and lying on the floor, hands up on the couch. I typically want something about 19 inches in height. You have to take into effect if it's cushy and sinks, but people have different sizes of torso, so I changed it about. But I tend to find lying on the floor, propping up like this, as long as the neck can take it, the chest can take it, is going to be significantly more force than getting on your elbows and just going up on books. There's something about it, in my experience, that lifting the shoulders into flexion, even kind of grabbing the cushion edge of the back of the couch, just getting that extra kind of extension through the spine, in my experience, tends to be a lot more fruitful and probably more forced than just getting into extension by being propped up. So we did 10 seconds, then we did a couple sets of 15 seconds, then 30 seconds, then 45 seconds. I wasn't just going to a full minute from the beginning. I wanted to approach it cautiously, just like with anyone, because it's a lot of force and you need to see how they respond before you tend to increase that force. So better toe touching after that, in the long sitting position on the floor, better flexion, better extension, no pain with the side glide. So I told her I still think she's missing some extension. She may have been missing it for a year, 10 years, 20 years, I'm not sure, but I wanted her to get back her full extension. I think having your full range of motion and knowing how to keep your full range of motion in any joint is the best way to minimize recurrence of injury, especially since most of these injuries are non-traumatic, right? They just happen. So I asked her to do the sustained extensions on the couch, about 45 seconds or more every couple hours. Continue with the side glides 2 times a day, just to make sure all of this extension isn't hurting those gains that we made from moving to the side, because they're very opposed movements. We abandoned the middle position, which is the extension with the hips and a side glide. I didn't think that was necessary to continue. I don't find with patients I can really get that in a sustained position effectively, so I haven't tried much, but again, if you test the pure extension and you're seeing results, then let's just go with the pure extension. So I told her to use a lumbar roll if it tended to be helpful. incorporate lunges back, or start working out more with the lower body. So incorporate lunges at 50% of her past weight. Do the exercise before and after the workout just to be conservative. And you know, that in the future we would get back to squats and deadlifts and all the things that she was doing. After a week or two, she had emailed me and said she felt great. I know that we had already touched on what does the maintenance plan look like for her. We'd mentioned this several times because I want to kind of prepare people for what it's going to be like. And I tell people, look, you might need a side glide every day, you might need an extension every day, you might need it once a week. It really is based on how your body responds to all the other mechanical loads in your life. If you are working out heavy in flexion, if you are sitting in a chair that's tons of flexion, you may need extension, but you may need side glide. You have to kind of self-experiment. And I'm there to help people with that self-experimentation, but it comes down to what does that individual spine need based on the previous mechanical loads in the 40 plus years of life it's had, and based on the new loads that you're putting on it. If there were a better way to keep the spine mobile and healthy, I am all ears. But what I'm finding is that the movements that got the person out of the predicament they were in tends to become the maintenance plan. For people who have been shifted, I find that some lateral motion, usually a side glide, is indicated, like I said, maybe on a daily basis, maybe on a weekly basis, maybe only when you feel stiff. You can be proactive and say, I'm gonna do these 2 exercises every day. It's gonna take 2 minutes of my day, and it's really important for me to have a mobile spine so that I feel good and I can exercise and I can walk and I can sit without pain and sleep without pain. Or you might be the kind of person who said, I don't really challenge my back that much. If I sit up straight or if I do X, Y, Z, I probably can just respond if it gets a little stiff. We want people to have that choice. For me personally, I do my exercises or my movements that help me on average once a day, sometimes twice. Depends on the loads I'm putting through my spine, especially at the gym. But I want to keep it healthy and mobile. I'd rather do that proactively for 1 to 3 minutes per day than be reactive and have it be stiff and or painful and take away from my functionality for a few days. If I'm proactive, I'm much less likely to have days where I just can't do squats, for example, or can't do sit-ups, or can't sit comfortably, for example. So this was 5 visits. I asked the patient, she said, I'm doing great, what do you recommend? I said, look, if you'd like me to come in a week or 2, I can check your range of motion, strength, nerve tension, check you out, make sure we're on the same page for the maintenance program and return to activities in the gym. If you feel like you've got it under control, we don't need to meet again. I didn't hear from her, so I'm assuming she's good to go. But she does have an idea, because we touched on it repeatedly. What does this look like? How do you keep your spine healthy? She already had a past occurrence of sciatica. This is the second. She knows that it took her out for a month and a half and that she was miserable. So she is more inclined to be on board with doing something to keep her healthy. Those are the maintenance strategies that I present to people. It's really about how do you keep your full range of motion. If you have a trick that keeps your full range of motion, I'd like to learn about it. But my trick is do the things that restore the full range of motion when we did them extensively every 1 to 2 hours. Do them as needed or proactively, even when you don't need it, just to keep you from getting stiff. Do them as much as you need to keep your full range of motion, because the full range of motion is more likely to lead to the nerves moving well, the muscles working well, versus the other way around. So please post questions or comments if you think I'm doing something wrong or can do something better. Let me know about that too. I'm always looking to get better, but I think treating kind of significant radiculopathy, significant nerve root irritation that is affecting a person for over a month, all the way down into the toes, in 5 visits with 3 exercises, yes, but mostly just 2. I think that's in a very efficient musculoskeletal orthopedic treatment journey. I wish I had performed this way or approached musculoskeletal injuries this way years ago, but it's after learning repeated movement testing, which was created by Robin McKenzie, and using that in this patient example. So what did I do after I took the history and the physical exam on day 1? Is I didn't do an x-ray test, I didn't do an MRI test, I didn't do a prone instability test, I didn't do any of those orthopedic special tests. I did repeated movement testing. I chose, based on the fact primarily that this patient was shifted visibly to the side, I chose as the first repeated movement test side gliding to get that spine straight again. And then once it's straight, you can decide where to go from there. But repeated movement testing is the test that I find is the most effective test in the large majority of orthopedic cases. However, most clinicians do not learn repeated movement testing, also known as mechanical diagnosis and therapy, or MDT, or the McKenzie method. Most clinicians do not learn it because it's not taught in academia, unfortunately, and it requires going to courses and reading outside of work once you graduate and become a clinician. I wish it were taught in schools, of course. There are 5 textbooks by Robin McKenzie and Stephen May. There are simpler books geared towards a layperson like Treat Your Own Back. I recommend people checking those out if they're stuck, but finding a clinician who is certified in mechanical diagnosis and therapy, or like me, the higher level, I have a diploma in mechanical diagnosis and therapy, which means I took months of my time, lots of money, time off from work, traveled to Texas to learn from mentors, studied online, because I really believe in this type of orthopedic testing. I obviously believe in other orthopedic tests, but like I said, for most people, we need to see, is there a movement or 2, or in this case, maybe 3, which is very rare, that will get the joint back on track, get things moving well. When that joint is moving well, muscle strength should return, nerve extensibility should return, symptoms should abolish, and function, of course, should follow. If you're moving well and have strength, you should be able to do the things in your daily life, i.e. function. Like I said, leave comments or questions and I'll do my best to answer any questions. Thanks for watching.